have you joining us for another Rush Generations lecture today, May 3rd, 2023. My name is Kim Morley, and I am the program coordinator for Rush Generations. And this lecture is being brought to you by the Social Work and Community Health Department here in Chicago, Illinois. Today's lecture is titled Men's Health Roundtable. And for this lecture, we are delighted to have one of our esteemed Rush providers sharing his expertise on men's health. First, I want to begin by thanking our lecture's producer, Hannah Weitzman, for her assistance with producing this lecture, as well as her technical support. Also, we don't want you to miss any Rush Generations lectures and videos, so if you're listening on YouTube, please click the subscribe button and turn on your notifications to stay up to date on all of our new content. Thank you to those of you who are joining over the phone and on YouTube. For those listening on YouTube, if you have any questions for our speaker, please type them using the live chat button located in the bottom right hand of your screen. Your questions will be answered at the end of the lecture. For those of you listening over the phone, there will be an opportunity to unmute yourself at the end of the lecture. Now for our presenter today. Dr. Jonathan Huang is a urology specialist, and he completed his residency at Emory University in Atlanta, Georgia, and his fellowship training at Yale University. Dr. Huang specializes in the treatment of complex kidney stone disease, as well as minimally invasive surgery for kidney, prostate, and bladder cancers. He currently works at Rush Copley Medical Center in Aurora, Illinois, and has been there now for 5 years. Thank you, Dr. Huang, for presenting to our Rush Generations and community members, and I will hand it over to you.
Start video and unmute, and then I'm going to share my screen, okay? Let's see. All right, so you can see my slide?
Yes, that looks great.
Okay, perfect. So good afternoon. I wanted to start off by thanking Ms. Morley, Ms. Weitzman, and the Rush Generations team for inviting me to speak today. I also like to thank you, the audience, for taking time to participate in this session. I'm Jonathan Huang, one of the urologists at Rush Copley. My goal today is to provide some helpful information regarding men's health as it pertains to urology. My plan is to first review some general background information about urology and the urinary tract. Then we'll cover a few topics that patients often present to the urology clinic with. We'll discuss the evaluation and general management of an enlarged prostate. Next, we'll discuss prostate cancer screening. We'll then turn our conversation over to erectile dysfunction. And then lastly, we'll cover the management of testicular pain. So first, general background information. So what is urology? Urology is the medical field that manages conditions related to the male and female urinary tract. In urology, we also treat conditions related to the male reproductive system. We perform common surgeries such as kidney stone removal. We help to manage more personal issues such as infertility, and we also treat cancers such as testicular cancer, prostate cancer, bladder cancer, and kidney cancers. I wanted to briefly describe the urinary tract. So on the right side of the screen is a picture of the male urinary tract. The kidneys are organs located at the flank, which is on either side of the mid-back. The kidneys filter the blood, and this helps to regulate a person's electrolytes. Filtration of blood results in the production of urine. The ureters are tubes that drain the kidney. They connect the kidney down to the bladder. The bladder is an organ that stores urine, and the bladder is located at the suprapubic region at the lower abdomen. The prostate, it's an organ that's only found in males, and it's also located beneath the bladder. The location of the prostate is important because many of the symptoms that men experience with urination are a result of the prostate. And the last part of the urinary tract is the penis. This organ functions as a reproductive organ, but is also a conduit for urine. So let's discuss what having an enlarged prostate means. As men age, it's normal for the prostate to increase in size. One of the terms we use to describe this condition is benign prostatic hyperplasia, or BPH. A normal prostate is typically less than 30 grams in size. One study found that men in their 40s usually have a prostate that's about 25 to 30 grams in size. In contrast, men in their 60s usually have a prostate that's about 35 to 40 grams in size. If you remember, the prostate is located beneath the bladder, and the urethra passes through the middle of the prostate. So if you look at the picture on the right-hand side of the screen, when the prostate increases in size, this compresses the urethra and makes it more difficult for men to urinate. This can lead to obstructive urinary symptoms such as a weak stream, straining with urination, and hesitancy. This can also present as irritative symptoms, including urinary frequency, urgency, painful urination, and having to wake up often at night to urinate. Some more serious symptoms include urinary retention, urinary tract infections, blood in the urine, kidney failure, and bladder stones. In the office, we will sometimes provide patients with the International Prostate Symptom Score. This questionnaire asks questions regarding a patient's urination, including symptoms of whether they have incomplete emptying of the bladder, whether they have frequency, intermittency, urgency of urination, whether they have a weak urinary stream, whether they have to strain in order to urinate, whether they have to wake up at night to urinate. This questionnaire also asks the patient subjectively about their quality of life. And based on these scores, patients can be separated into having mild symptoms, moderate symptoms, and even severe symptoms. And the treatment can be based on the severity of these symptoms. In patients whose symptoms are tolerable or mild, we typically recommend starting with conservative management, which are techniques, lifestyles that can help improve their symptoms. For instance, we often like to discuss double voiding in patients who have obstructive symptoms. What this means is that after urinating, we ask the patient to stand there for maybe another 30 seconds, 60 seconds or so in order to urinate some more. The goal is to try to have them empty the bladder as much as possible. For symptoms such as urinary frequency and urgency, sometimes timed voiding can be implemented. Using the restroom at regular time intervals prevents the bladder from becoming overly full, which can help a patient avoid that urgent sense to urinate. Bladder irritants include substances such as coffees, alcohol, spicy and acidic foods. Some of these cause the kidneys to actually produce more urine, while others irritate the bladder. So minimizing these products can sometimes help with the urinary frequency and urgency. For moderate and severe symptoms, we usually start with oral medications. There are two classes of medicines used as medical therapy for these urinary symptoms that men experience due to an enlarged prostate. The first class is an alpha-1 receptor antagonist. The goal of this class of medicine is to help relax the smooth muscles at the bladder neck and along the prostatic urethra. These alpha-1 receptors can also be found along arteries. That's why some of the alpha-1 receptor antagonists, specifically the non-selective ones, have more noticeable side effects. Non-selective alpha-1 receptor antagonists include prazosin, terazosin, doxazosin, and alfuzosin. The selective alpha-1A receptor antagonists include silodosin and tamsulosin. Side effects of these medications include hypotension, meaning decreased blood pressure, lightheadedness, and flushing of the face. Another side effect is retrograde ejaculation. This is not harmful, but sometimes when patients don't know about this condition, they get a little bit upset. And patients on tamsulosin have a higher propensity to develop intraoperative floppy iris syndrome, which can make cataract surgery more challenging. The other class of medicine often used for patients with enlarged prostate is a 5-alpha reductase inhibitor. This class of medicine prevents testosterone from being converted into dihydrotestosterone, or DHT. DHT is a more potent form of testosterone, and it helps promote prostate growth. So the use of this medicine reduces prostate volume by about 25% over a 3 to 6 month period. Two medications within this class are finasteride and dutasteride. Side effects of this medicine, of these medications include decreased libido, as well as erectile dysfunction. Some patients also will report breast enlargement called gynecomastia and breast tenderness. Something to keep in mind while on this medicine is that 5-alpha reductase inhibitors will decrease the PSA by about 50% at a 6-month period. This is important with regards to prostate cancer screening. For example, if a patient's PSA is 4.0, which is at the upper end of normal, and he's on finasteride, his true PSA may actually be 8.0, which is concerning for prostate cancer. This is one of the landmark studies in the field of urology. This study was published in the New England Journal of Medicine. This study was entitled The Long-Term Effect of Doxazosin, Finasteride, and Combination Therapy on the Clinical Progression of Benign Prostatic Hyperplasia. The purpose of this study was to evaluate whether an alpha-1 receptor antagonist and a 5-alpha reductase inhibitor individually or in combination can prevent worsening of symptoms in men with BPH. Their primary outcome was time to clinical progression of BPH. This was a multi-centered, randomized, double-blinded, placebo-controlled trial, so a very well-executed study. There were about 3,000 patients enrolled in the study. What they found was that the combination of doxazosin and finasteride was more effective together than either therapy alone. Doxazosin alone had a risk reduction of 39%. Finasteride alone had a risk reduction of 34%, and the combination therapy had a risk reduction of 66%. When medications are no longer effective, surgery is considered as last resort. A TURP, or transurethral resection of the prostate, is an endoscopic surgery that's usually completed under general anesthesia. In patients who are more frail, or sometimes in third world countries, this surgery can be completed under spinal anesthesia. This surgery involves the mechanical removal of obstructive prostate tissue. This allows there to be less resistance during urination. Some patients like to refer to the surgery as the Roto-Rooter surgery. It's somewhat analogous to coring out the inside of an apple. The picture at the bottom left shows the obstructive lobes of the prostate pre-resection. You can see that on either side of the channel are the obstructive lobes. The picture on the right shows a wide open channel into the bladder post-resection. You can see that we had resected those obstructive lobes. It's important to keep in mind that this surgery does not cure prostate cancer, and that patients can still develop urinary retention after this surgery. These patients are typically with us overnight on continuous bladder irrigation in the hospital, and they're discharged on post-op day 1. We typically remove their Foley catheter sometime between post-op day 1 to 3. Risks that are more pertinent to this surgery include leakage of urine due to stress, urinary incontinence, retrograde ejaculation, and burning with urination. More recently, over the past decade or so, newer procedures such as urolift, Rezum, aquablation have been developed. They share the same general principle of widening and opening up the channel in the urethra. This is a cartoon picture of what occurs during a transurethral resection of the prostate. You can appreciate that the prostatic urethra is being mechanically widened, and all the way on the right, you can see that there's a wide open channel into the bladder. So next, we'll move on to prostate cancer screening. So large population studies have found that prostate cancer is the most common non-skin malignancy in males. It ranks ahead of lung cancer and colorectal cancer. About 225,000 cases of prostate cancer were diagnosed in the US in 2019, based on information from the CDC. While prostate cancer is the most common non-skin malignancy in males, it ranks second in terms of deaths per year, whereas about 75,000 men in the US died of lung cancer in 2019. Only 32,000 men died of prostate cancer. And studies have shown that about 80% of prostate cancer is localized at the time of diagnosis. What this means is that prostate cancer is very treatable, very curable. As all men age, they are at higher risk for developing prostate cancer. A common phrase we use in the field of urology is, or with regards to prostate cancer, is that most men will die with prostate cancer, not because of prostate cancer. One autopsy study found that about 50% of Caucasian and African American men who died in their 70s to 80s from a cause other than prostate cancer had incidental prostate cancer on their autopsy. But what are other risk factors for prostate cancer? There's certainly a genetic component. Studies have found that African American men are twice as likely to pass away from prostate cancer than their Caucasian counterparts. Also, African American men tend to develop prostate cancer at a younger age, and have more advanced disease at diagnosis. Studies have also shown that men with a first-degree relative with prostate cancer are at 2 to 3 times increased risk of having prostate cancer, and the risk is further increased if the relative at early age of diagnosis. There isn't any conclusive data regarding the association between diet and prostate cancer. There have been numerous studies conducted around the world that have looked at various dietary factors. The results tend to usually be mixed, but some meta-analyses have shown a possible positive association between saturated fats and red meats with prostate cancer, and that lycopene, which is a substance found in tomato-based products, and soy products can potentially decrease the risk of prostate cancer. But the results from these analyses did not reach statistical significance. Prostate cancer can manifest in a number of different ways. Oftentimes in early stage or localized disease, there are no symptoms. In more locally advanced disease, there can be obstructive symptoms or irritative symptoms. There can be urinary retention if the urethra is compressed. There can be blood in the urine or semen, as well as sometimes having pelvic pain. With metastatic disease, patients often will report bone pain or symptoms of spinal cord compression. Prostate cancer, when it spreads, tends to spread to the spine. Screening for prostate cancer was a hot topic in medicine about 10 to 15 years ago. The USPSTF, which is the national governing body that produces these screening guidelines, actually recommended against regular screening. Their recommendations were based on these 2 studies. The PLCO study, which was performed in the US, reported that screening for prostate cancer did not prevent prostate cancer death. But what they didn't realize was that over 90% of the men in the control group who are not supposed to be screened regularly actually did have prostate cancer screening. So when they compared this group to the group of men who did have regular prostate cancer screening, as you can imagine, the researchers did not find a significant difference. The ERSPC study, which was performed in Europe, found that 781 men needed to be screened to detect 27 cases of prostate cancer in order to prevent 1 prostate cancer death. So the researchers reported that screening was not beneficial because many men needed to be screened in order to prevent a small number of prostate cancer-related death. The American Urologic Association has published their own guidelines regarding prostate cancer screening. For men less than 40 years of age, they recommend against screening. The likelihood of having prostate cancer is low at this age. For men between the ages of 40 and 54, they recommend against routine screening for the average risk patient. For men with a family history of prostate cancer, or African American men who have been shown to be at higher risk for prostate cancer, screening can be considered. For men between the ages of 55 and 69, the AUA recommends that the decision for screening be discussed between the patient and their provider. The risks and benefits of screening should be discussed. For men over the age of 70, they recommend against routine screening as the likelihood of passing away from prostate cancer at this age group is low. But sometimes patients who are healthy, who are active and fit, prostate cancer screening can still be considered. The goal of screening is to detect lethal prostate cancer at an early stage so that we can intervene with a curative intent. What screening for prostate cancer involves is twofold. The first component is a blood test that assesses a patient's PSA level. This is the prostate-specific antigen. This is a protein found in and secreted by the prostate, which can be tested by sampling a person's blood. Something to keep in mind is that PSA is a non-specific marker of the prostate. What this means is that many different causes can lead to an elevation in this level. For instance, having a urinary tract infection can cause the PSA level to be elevated. Having an enlarged prostate can cause the PSA level to be elevated. But what we're most concerned about, prostate cancer can also lead to an elevated PSA. The second component of screening is a digital rectal exam in the office. This allows us to assess the prostate. What we're trying to see is, are there any suspicious masses on the peripheral zone of the prostate, and also to see how big, what the size of the prostate is. Anatomic studies have looked at the distribution of prostate cancer and found that about 75% of prostate cancer is located at the peripheral zone of the prostate. So doing a rectal exam, sometimes we're able to palpate nodules and masses. As we discussed, PSA is a non-specific marker of the prostate. So what's considered a normal PSA level? You can see from this table that PSA tends to increase with age, and ranges of normal can also vary with race. In general, our upper end of normal is 4.0. The PSA velocity and PSA density can also be used to help guide our decision as to whether additional testing is needed. If a person's PSA increases by more than 0.35 in a year, this may suggest that something other than just having an enlarged prostate is causing this rise. Also, dividing the PSA level by the volume of the prostate gives us a PSA density. Some researchers have suggested that a PSA density greater than 0.15 is associated with prostate cancer. If there are abnormalities in the PSA level or a suspicious nodule is palpated on rectal exam, a prostate biopsy may be warranted. What a prostate biopsy involves is first a transrectal ultrasound assessment of the prostate. We use the ultrasound to assess the volume and the shape of the prostate. Sometimes this can help with surgical planning. We also look for suspicious areas within the prostate. We then instill lidocaine, which is a local anesthetic, to help numb the prostate. Then biopsies are taken systematically at 12 different locations throughout the prostate. A prostate biopsy isn't completely benign. While the prostate biopsy typically is not too painful, it can still be a little bit uncomfortable. There's also a risk of infection. One study assessed about 400,000 prostate biopsies from 300 referral regions over a 2-year period. They found that about 1.6% of patients developed an infection that required hospitalization. At Rush, we have previously reported an infection rate that was a little bit lower at 1.1%. We attribute this decreased rate to the urine culture and the rectal culture we performed prior to the biopsy to look for resistant organisms. Other risks of a prostate biopsy include having blood in the stool, urine and semen, and a small risk of urinary retention. Some physicians nowadays will also perform a prostate biopsy through a transperineal manner. So the perineum, it's the area between the scrotum and the anus. Performing a biopsy through the perineum is another method to lower the risk of infection. After the biopsy is completed, the specimen, at least at Rush Copley, is analyzed at our lab at Copley. Each set of prostate biopsy cores is discussed with the pathology lab at Rush University for confirmation. If there's a question of the disease grade or a second opinion is required, the specimen is then sent to Mayo Clinic for a second look. The goal of all these reviews is to make sure that we have the correct diagnosis, because this determines whether the prostate cancer is low risk, intermediate risk, or high risk. On the right side of the screen is what the pathologist sees underneath the microscope. They classify the tissues as Gleason 3, Gleason 4, or Gleason 5 based on how well differentiated the tissues are. This helps to determine the aggressiveness of the cancer. The pathologist looks for the most common and then the second most common pattern, and then sums up these two values to determine the grade group. The grade group is another method to classify the aggressiveness of the prostate cancer. This graph shows the reason why knowing the grade group is important. Each line going from top to bottom is an increase in the grade group. As the grade group increases, there's a decreased chance of being disease-free over time. In other words, there's a lower chance of recurrence-free progression. A multiparametric MRI is usually performed when a patient had a negative prostate biopsy, but his PSA level continues to rise. Sometimes urologists will also use the MRI prostate for the initial prostate biopsy. The MRI prostate provides detailed information about the prostate, including its volume and whether there are enlarged lymph nodes. But more importantly, the MRI prostate looks for lesions within the prostate and then classifies them based on how suspicious they are for cancer. A targeted biopsy still needs to be performed in order to confirm the diagnosis. Based on the rectal exam, the pathology from the biopsy, and the PSA level, a patient can be either classified as having low-risk prostate cancer, intermediate-risk prostate cancer, or high-risk prostate cancer. There's also these other subcategories of very low risk, or separating intermediate risk into favorable and unfavorable, and very high risk. These risk groups are used to tailor the treatment and the management of prostate cancer. With regards to treatment options for prostate cancer, there's basically 4 general categories. This can be a whole talk in and of itself, so today I'll only briefly discuss these options. Active surveillance, which is basically close monitoring, is oftentimes recommended in patients with very low risk and low risk prostate cancer. Surgery, which is most often a radical prostatectomy, is a treatment option for each risk group, as long as the cancer is localized. Radiation therapy, which can come in various forms, is also a treatment option for each risk group, as long as the cancer is localized. However, with surgery and radiation, there can sometimes be somewhat substantial side effects. Hormone therapy, which is also called androgen deprivation therapy, is commonly used when there is metastatic prostate cancer. So then we'll move on to erectile dysfunction. The American Urologic Association defines erectile dysfunction as the recurrent inability to attain or maintain a penile erection sufficient for sexual satisfaction. This problem is a little bit more common than most people think. The Massachusetts Male Aging Study looked at approximately 1,700 men and found that the prevalence to be about 52%. The study found that age was the variable that correlated most strongly with erectile dysfunction. The study found that about 40% of men at age 40 are affected, and that 70% of men at age 70 are affected. Studies have found that erectile dysfunction impacts men in the areas of social function, their energy level, and emotional health. Erectile function is a complex event that involves a number of different systems. All these systems have to function properly in order for men to succeed. These systems include blood vessels, nerves, and hormones. So what are common risk factors associated with erectile dysfunction? Hypertension, meaning high blood pressure, hyperlipidemia, meaning elevated cholesterol, diabetes, tobacco use. These are the main culprits for erectile dysfunction. These can lead to narrowed blood vessels and impairment of the nerves. Workup involves a good history and physical examination. We're assessing for these risk factors and other contributing factors. Labs can also be helpful to evaluate a person's hormone profile, as having low testosterone can contribute to erectile dysfunction. We also sometimes use a questionnaire called the International Index of Erectile Function. This helps us to quantify the severity of ED. Based on the severity of a person's erectile dysfunction, various modalities and treatment can be considered. If the symptoms are mild, we'll usually recommend conservative management. This involves lifestyle changes such as improving blood pressure and blood glucose. Exercise and a healthy diet are also important. Quitting tobacco use can help to improve erections. But remember, erectile dysfunction is a problem that typically gradually developed over years. So improvement in erectile dysfunction with just conservative management will also take time. One study evaluated a subset of men that was placed on a weight loss program. What this study found was that over a 2-year period, 1/3 of the men on the weight loss program noted complete resolution of their erectile dysfunction. Another study evaluating the role of quitting tobacco noted that about 25% of men reported improvement in their erectile dysfunction after quitting tobacco for 1 year. When conservative management fails, the next line of treatment for erectile dysfunction is oral medications. This is the class of medications that sometimes you'll see advertised in magazines or on TV. I read somewhere that pharmaceutical companies spent over $300 million on advertising for erectile dysfunction medications each year. These oral medications all work the same way. They inhibit the breakdown of a substance that dilates the blood vessels. As such, this keeps the penis erect. The main difference between Viagra, Cialis, Levitra is their half-lives. So they're excreted from the body at different rates. Side effects of these medications are related to the dilation of the blood vessels. So side effects include decreased blood pressure, headaches, and flushing of the face. People who have had heart attacks in the past are prohibited from taking these medications unless cleared by their cardiologist, as these medications can sometimes increase the risk of a heart attack. When oral medications aren't successful, alternative treatments include medications that can be injected directly into the penis, tablets that can be inserted into the urethra. There's also a vacuum erection device that basically draws blood into the penis. And last resort is a penile implant called an inflatable penile prosthesis. I wanted to briefly touch on over-the-counter supplements for erectile dysfunction. Not too long ago, the FDA published an article entitled All Natural Alternatives for Erectile Dysfunction, a Risky Proposition. The gist of this article is basically to take caution when considering these supplements. Many over-the-counter medications are not FDA approved. As such, they may contain undisclosed ingredients. They may potentially have excessively high dosages and can have risky interactions. Nowadays, some of the oral medications we use come in generic forms. In our urology clinic, we prefer to use a mail order pharmacy and prescribe the generic form of Viagra, as this can be significantly cheaper. And then lastly, we'll discuss the condition of testicular pain. The testes are reproductive organs located within the scrotum. The size and firmness is similar to that of a hard-boiled egg. The testes are attached to the spermatocord. The spermatocord contains the arteries and veins, basically the blood vessels to the testes. It also contains the vas deferens, which is the tube that sperm travels through. The function of the testes are to produce sperm for reproduction and to produce and synthesize testosterone. Testosterone helps with reproduction and is also necessary to maintain energy and a male's general well-being, including their bone health and their cardiovascular health. A term that we'll sometimes use in urology is an acute scrotum. The patient with an acute scrotum will oftentimes have new onset pain and swelling of their intrascrotal contents. One study reported that genital urinary complaints, of which an acute scrotum is a part of, comprise about 2.5%, up to 2.5% of ER visits. This type of pain often will have a rapid onset. So when a patient presents with an acute scrotum, the differential diagnoses include, is it an ischemic or traumatic condition? Is it an infectious condition? Or could it be a neuropathic or referred cause of pain? The conditions that or specifically the condition that we're most concerned about is testicular torsion. Evaluation begins with a good history and physical. Onset and duration is often helpful to know because testicular torsion usually has a rapid onset. I've had a patient with torsion who presented to the ER within an hour of onset. Also, being aware of associated activities can help to narrow the differential. If the patient's pain started after lifting a heavy object, this could be more related to a hernia. Or if the pain started after being struck in the scrotum with a baseball, the patient could have a testicular rupture or a hematoma. Knowing associated symptoms can also be helpful. Nausea is very common with testicular torsion. If a patient has fevers or burning with urination, the testicular pain may be more infectious in nature. For the examination, if a patient's vital signs note an increased heart rate, this can sometimes suggest an infection. But keep in mind that pain can also lead to an increased heart rate. Palpation of the testes allows us to assess their size, their firmness, and whether there's tenderness to palpation. Lab work, including a white blood cell count and urinalysis, can be helpful to assess for infection. But what the mainstay of evaluation involves is a scrotal ultrasound with Doppler. What we are looking to see is whether there are changes to the blood flow to the testicle. In testicular torsion, what will be seen on scrotal ultrasound is no blood flow to that testicle. This is a urologic emergency. Urologists will oftentimes say, time is testicle. What this means is that the sooner intervention can occur, the higher the chance of saving the testicle. If surgery can be started within 6 to 8 hours of onset, there's usually a higher than 80 to 90% salvage rate. What surgery involves is exploration of the scrotum. The scrotum is divided into a right side and a left side. We first start with the side of concern. We will attempt to untwist or detorse the testicle. If that testicle regains blood flow, we will perform an orchiopexy, meaning we'll try to secure the testicle to the wall of the scrotum. This will ideally prevent torsion from occurring in the future. If the testicle is not viable, the testicle will need to be removed. When a patient had a torsion on one side, they're also more likely to have torsion on the opposite side. As such, we also perform an orchiopexy on the contralateral side. For infectious causes such as epididymal orchitis, Doppler ultrasound is also helpful and will usually show increased blood flow to the testicle. The main method of treatment is antibiotics, so patients will usually be prescribed antibiotics, and then we'll have them follow up with us in the office to assess for improvement and resolution. There are other various causes of scrotal pain. Some benign findings that are often reported on scrotal ultrasound include hydroceles, varicoceles, and epididymal cysts. A hydrocele is due to fluid accumulation in front of the testicle. A varicocele is due to dilated veins within the spermatic cord. And an epididymal cyst is due to a collection of sperm in the epididymis. For these findings, we usually recommend starting with conservative management. This includes supporting the scrotum, so briefs, boxer briefs, so that there's less up and down movement of the testes. Anti-inflammatory medications such as ibuprofen can help with the discomfort, and ice packs can also help. If conservative management is not effective, sometimes we can prescribe prescription medicines. And then surgery, as always, is considered last resort, as there's always risks to surgery, and the pain, unfortunately, may not always improve. So I want to thank you for your time today. If you ever have any questions, concerns, don't hesitate to reach out to Rush's urology department. We're always happy to help. Thank you very much.
Thank you so much, Dr. Huang. That was an awesome presentation and very comprehensive information on men's urologic health. You covered, so much for us today. And I know that there are probably several questions about that information. So for anyone who is listening on Zoom, please feel free to unmute yourself by pressing *6. And for those of you who are watching and listening via YouTube, please enter any questions that you have in the chat box, and we will ask Dr. Huang to answer those. While we're waiting to see if any additional questions come through, there were several that have been posed already. One is about the questionnaire that you had at the beginning, the International Prostate Symptom Score. Yeah. I know that you had mentioned screening against like prostate cancer, like routinely, for certain age groups. Is that questionnaire completed more often because it's like less invasive? Could you tell us more about that?
Yeah, so the International Prostate Symptom Score, it's related more to kind of urinary symptoms. So the prostate, it can kind of, there's kind of two general categories of conditions that we're concerned about. The International Prostate Symptom Score is used to, for the urinary symptoms, so kind of benign conditions. So when men have, like a weak stream or have to urinate frequently, sometimes we'll give them that questionnaire to kind of see how bad their symptoms are. So that's kind of separate from actually prostate cancer screening. So prostate cancer screening, we don't use that questionnaire. Typically when I see a patient in the clinic, if they're between the ages of 55 and 70, I'll offer them the option of the blood test and the rectal exam to see if they want to start screening for prostate cancer. It's kind of interesting. So sometimes, men with kind of significant urinary issues, they'll come to me and be like, oh, could this be related to prostate cancer? And, the short answer is possibly it could, but usually more often it's just due to just having an enlarged prostate. And then kind of in the reverse, if a person has prostate cancer, has been diagnosed with prostate cancer, they don't always have symptoms too. So, I think evaluating kind of both these benign urinary symptoms and screening for prostate cancer is important for men.
Okay, thank you. Yeah, that makes sense. That you can, have symptoms for one, but it may not be part of the like prostate cancer screening process. Correct. And yeah, okay. And when it comes to like, men's urologic health, are there ever recommendations of when to just like start seeing a urologist, or is it more like symptom indicated or symptom based? Could you tell us more about that?
Yeah, I would say it's more symptom based. I mean, this is separate, but kind of like colorectal cancers. I think historically the screening age was 50 and kind of got moved earlier to age 40. So, but screening for prostate cancer, it's always been kind of at age 55. So, I would say patients should, it'd be very reasonable to start seeing a urologist at age 55, but then, men, sometimes they'll start developing these urinary symptoms a little bit earlier, age 40, late 40s, early 50s. So I would say if they start having those symptoms, it's reasonable to start seeing a urologist even earlier than age 55.
Okay, sounds good. And another question that came up is for someone who has an elevated PSA, like, somewhere between 4.0 and 6.0, but doesn't seem to have an enlarged prostate, and an MRI was negative. Do you have recommendations on, how to best proceed with that?
Yeah, so I mean, I've seen kind of patients with similar questions, similar presentations in the past. So, all of these tests, whether it's the PSA and the MRI, it doesn't always confirm or, tell you 100% whether there's prostate cancer. So, in general, if a patient has kind of a persistent elevated PSA above 4.0, even if the MRI is negative, I would encourage, a prostate biopsy. And specifically if their PSA is above 4.0 and kind of continues to trend upwards, that may make me more kind of worried for prostate cancer. Because, I don't think we can just kind of put our mind at ease, if the MRI shows nothing, because there's still a small chance that there could be prostate cancer that's not detected.
Okay. So as opposed to just stopping right there, it could be helpful to advocate if the provider isn't saying the next step we should do this, maybe inquiring about having a biopsy.
Correct. Yeah. Because, having a prostate biopsy, having tissue that the pathologist can analyze is the only way to confirm yes or no if there's prostate cancer.
Okay.
I have patients who are still a little bit wary, a little bit leery. And, if that's the case, I think that's, very reasonable to have those kind of fears, kind of, concerns. I'll tell them that we should have kind of relatively close follow-up. We can perhaps check another PSA in 3 months, 6 months, kind of see how it trends. And then if it's stable, I'd probably feel more comfortable watching it, observing. But if we find that there's a consistent trend upwards, that may make me more, like to encourage, a prostate biopsy.
Yeah. Thank you for that direction and recommendation. Another question that came up is focusing on erectile dysfunction. I know that you had talked about some of the common causes that might be medical conditions or behavioral or lifestyle choices. Are there also medications that could possibly cause erectile dysfunction? For example, psychotropic medications that can sometimes be a side effect is sexual dysfunction. Could you speak a little bit more about that?
Yeah, so there are numerous medicines that can, sometimes affect erections. In the talk, we kind of briefly brought up finasteride, which is a medicine that men take to help them urinate better. That can kind of decrease the libido, cause erectile dysfunction. Sometimes some of the blood pressure medicines that are meant to lower the blood pressure can also cause erectile dysfunction, because if you can imagine, if the blood pressure is decreased, there's less blood per se kind of pumping to the penis, so that can cause erectile dysfunction. Some of the psych medicines can also sometimes increase or decrease the risk of erectile dysfunction as well. I don't know kind of them specifically, but there's different classes that sometimes, some that can cause, a prolonged erection, others can kind of decrease erection. There's a class that they found specifically, they're called SSRIs. That class of medicine, sometimes people will take for kind of premature ejaculation. So there are medicines that can negatively impact erections.
Okay. Yeah, that's helpful to know. And when it comes to folks experiencing, let's say, erectile dysfunction, would you recommend that they talk to the provider that's prescribing the medication? Let's say if it is maybe a single medication, would you recommend them doing that, or when would you recommend that they come and see a urologist?
Yeah, so some of the primary care physicians, family doctors, they feel comfortable prescribing these oral medicines, which I think is very reasonable. There are others who don't want to or just don't feel comfortable. So I would say if the patient's PCP feels comfortable, I think it's reasonable starting with them. If they don't feel comfortable, they can see in urology. And then, I would say, we kind of briefly talked about how there's oral medicines as kind of first line therapy for erectile dysfunction. And then there's kind of second line therapies, injectable medicines, tablets that you put into the tip of the penis. We kind of deem those as second line treatments. And then the inflatable penile prosthesis, that's kind of last resort. So not all urologists offer these kind of second and third line therapies for erectile dysfunction. At Copley, myself and my partner, we only kind of prescribe the oral medicines. We have a colleague of ours at Rush University who does specializes in men's health, who, if necessary, we have our patients see him to discuss these second tier, third tier treatments.
Okay, yeah, that makes sense. And it sounds like the second and third tier, would those be like more severe cases of erectile dysfunction that have failed other lines of treatment?
Yeah, so I think describing it as more severe is a good kind of way. Sometimes patients they're just not responsive to oral medicines. They're in urology, we have a subset of patients who've had prostate cancer, had their prostate removed. And as a result of that, they have kind of significant erectile dysfunction. So sometimes oral medicines for that class of patients, isn't effective, and they need kind of injectable medicines. So I would say that patients who do need those second and third tiers, they do have kind of more severe erectile dysfunction issues. But I tell patients that specifically kind of the second tier treatments, the injectable medicines, the tablets that you put into the tip of the urethra, it is more labor intensive and it can be a little bit more uncomfortable, but usually once you've done it, once you've learned how to do it, it's usually not too bad.
Yeah, well, and it seems like that at least gives men the hope that if they do have more, let's say what you're discussing or describing as severe cases, that there are still treatment options available.
Correct.
Yeah. Another question that came up is what type of infections can cause testicular pain?
Yeah, so it's usually most commonly it's usually kind of due to a urinary tract infection, because the testicles, we talked about how they're connected via the vas deferens to the urethra. So sometimes if you have a urinary tract infection, the bacteria can be kind of transmitted down the vas deferens to the testicle. So, when patients have testicular pain and it seems more infectious in nature, we'll test their urine with a urine culture. Sometimes we'll see, E. coli, some of these enteric organisms. There also, can be, there's a virus specifically, called mumps that kind of affects the testicle and can cause swelling and pain too. But I would say most commonly it's because of UTI organisms such as E. coli.
And the treatment, I'm guessing, if it sounds like that's a bacterial infection, what would be the treatment for something like that?
Yeah, so a bacterial infection, typically we start with antibiotics. There's a class of antibiotics called fluoroquinolones that typically has pretty good tissue penetration. So patients with testicular pain, sometimes prostatitis, will prescribe that medicine to see if it helps. That class of medicine specifically has been shown to have more resistance nowadays, just because a lot of providers are using a lot of it. Bacteria is becoming resistant. So, we always try to be good stewards of antibiotics and make sure that we, give the appropriate one, not overprescribe the antibiotics. But if that one's not effective, there are other kind of classes of medicines that we will try. But typically, with what seems like a bacterial infection, we will start with antibiotics.
Yeah, thank you for that information. So that looks like all of the questions that came up throughout this lecture. I really appreciate, everything that you shared and your expertise in this area. And as you mentioned, people can get in contact with you or schedule appointments with you at Rush Copley. And do you practice anywhere else in the Chicagoland area?
So I'm just at Rush Copley, but Rush, they have a pretty big, footprint, across the city. At Rush University, I think, we have physicians that go to Oak Park, Oak Brook even now. So, all kind of along 290, I think. So.
Yeah, exactly. The West Side and beyond. So, yeah. Well, thank you so much again for your time. We really appreciate you spending time with our Rush Generations community, and hope you have a great rest of your day.
Yeah, thank you for allowing me to participate.
All right, take care.
All right, thanks.
And so for our last portion of our lecture today, we have our promotions of the Rush Generations current and upcoming programs. So we will discuss those. Starting off with our celebration of Older Americans Month, which is titled Aging Unbound. This will begin the week of May 15th. That's a Monday, and events for this celebration include a storytelling workshop where people can come in person to Rush to learn about ways in which they can tell their either like a healthcare story or just, a personal story about their life from a trained professional who has trained people on how to tell stories for different scenarios. So we would love to have you come in for that. It's a 1.5 to 2 hour event that we're hosting. We also have Jeopardy, which will be focused on healthcare questions. We have a wonderful healthcare that will also feature a dance portion. So that would be a really exciting event for you to come and see. And then we also have our Rush Generations ambassador onboarding. So if any of these events sound of interest to you, we would love to have you come back to Rush. We're really excited to be hosting people in person. So please call our 800 number for more information or to register for this event. Next is our Take Charge of Your Health workshop. That will be starting Fridays, May 5th and running through June 16th. And this is offered virtually. A little bit more information about our Take Charge of Your Health workshop. It's a free 6-week self-management workshop that is designed for adults with one or more chronic conditions. And in this workshop, people will learn how to build skills and gain confidence in managing their health and leading an active, fulfilling life. Topics that are covered throughout this workshop are coping with fatigue, pain and isolation, communicating with family, friends, and healthcare professionals about what your needs or wishes are, practicing good nutrition, evaluating new treatment options, and goal setting and problem solving. So registration is required and necessary for you to obtain the workshop materials. So please call our 800 number to get more information or to register. Next is our Learning to Live Well with Chronic Pain workshop, and this will be starting on Monday, May 8th and running through June 26th from 2 p.m. to 4:30 p.m. in the afternoon. And this will be held via Zoom. A little bit more information about this workshop is that it's a 6-week workshop for people living with chronic pain, and participants engage in discussions and skill building activities to better cope with the day-to-day management of chronic pain. All sessions incorporate an exercise element as well as strategies for medication management, pacing activity, and rest. And to register for this, you would still call our 800 number so we can get you set up. Next is our Friends and Family of People with Memory Loss Support Group. And this is offered every second Monday of the month, which would mean that our next group is meeting on Monday, May 8th at 6 p.m. until 7:30 p.m. And this is offered telephonically. And for more information or to register, please contact Janine Quinn at 312-563-0650. And we continue to offer our Friendly Caller program. This is focused on connecting socially isolated and lonely older adults with a trained volunteer for friendly weekly calls. These calls are designed to be participant-centered discussions, meaning that volunteers are calling to establish a friendship and make a genuine connection. There are no structured screening questions or interventions, and these calls can be as long or as short as you would like, up to an hour. So please call our 800 number if you are interested in getting connected with this program. And we also continue to promote our Rush Caring for Caregivers program. This is focused on providing support to caregivers who are taking care of an older adult. And in this, you will work with professionals to figure out the help that you need to care for someone who is 60 and older, and get personalized education and support, build an effective team, and create plans that work for everyone that's involved. So for more information on caring for caregivers, please call 312-563-0350. And another program that we continue to promote within our social work and community health department is the Rush Older Adult Home Modification Program. And this is designed for older adults to work with community and health professionals so that they can learn how to gain additional support with the goal of continuing to live at home safely. And so what is included in this is working with an occupational therapist and a home repair specialist to get personalized home evaluation recommendations. And there will also be professional installation of modifications that you choose to add to your home. And this can help with building confidence to continue living safely at home. And some of these services are even free to consumers who would qualify. So if this program sounds of interest to you, please call 312-942-6400. And lastly is our Shulman Senior Voices program. Shulman Senior Voices aims to empower older adults to discuss what matters most to them as they age. And it's important to share what matters most to you in regards to communicating with your physicians as well as your loved ones. So Shulman Senior Voices would love to hear from you. Please consider sharing your wisdom and why it's important for your healthcare team and loved ones to know your goals and wishes. So if you would be interested in recording a video, please scan this QR code with your smartphone or enter the web address above that to follow the prompts to record your story. And our next lecture will be coming up in 3 weeks on Wednesday, May 24th, and that will be our Women's Health Roundtable. And we're excited to have a panel of providers who will be reviewing women's health. And lastly, as we mentioned throughout these program reviews, our 800 number, which is 800-757-0202. Please call that if you have any questions about today's lecture, or if you're interested in registering or getting more information about the programs that we just discussed. Thank you so much for your time and attention today, and